Hello, everyone. Um, this is Muhammad Omar. It is my pleasure to present our case PCI of distal left main bifurcation with 5 cc of contrast, which I performed with Dr. Prelakis. I have no disclosure. This is a 90 years old man admitted with typical chest pain and non-ST elevation MI. He has a history of chronic kidney disease and hypertension transient ischemic attack. Interestingly, his EKG showed normal sinus rhythm with right bundle branch block. However, with chest pain, he developed significant ST depression in the infralateral lead and ST elevation in AVR, which was concerning for significant left main lesion. His echo showed normal LV systolic function. So we started with a diagnostic angiogram, which showed, as we expected, distal left main lesion, at least 50%, in addition to mid LAD lesion. Um, and then he also had distal RCA and PDA lesion. So the problem, in addition to his age, was creatinine was 1.7, and then one day after the procedure, it actually went up to 1.8. So we had an angiogram which showed left main lesion in addition to 3 vessel coronary artery disease. So we decided, after discussion with the patient and referring physician, to perform a PCI of the mid LAD and distal left main with a trial to minimize the amount of contrast as much as possible because of the patient non-chronic kidney disease. This was actually done before in multiple trial. One of them is a Mozart trial. IVUS guided BCI reduced the amount of contrast by more than 70%. And that's why the AC recommendation is at least to minimize the use of contrast. This is a class 1 recommendation in moderate or severe CKD patient. So we got vascular access through the femoral approach. We used 8 French 45 centimeter penicle destination sheath and 375 EPU. We confirmed the position of the needle with fluoroscopy and ultrasound. We did not use contrast. And we also confirmed the engagement of the guide by injecting saline, which usually produce dynamic T wave change, as we can see here. And then we wired the LED, the circ, and then the OM1 was a big branch, so we wired the 3 vessel. And then we deliver the IVUS to the mid LED. As we can see, IVUS actually showed the distal LED was 3O vessel, and here is a lesion, and then there is a lesion as well in the distal left main, actually at least 50%, because this is a 2O vessel here, and now it is 4O vessel in the proximal left main. So the IVUS was very useful for sizing, for mid LAD and the left main, and also for determination of the amount of calcium. So we started with a provisional approach for the mid-LAD. We used the calcium in the previous angiogram to detect the position of the lesion. Other option would be IVUS co-registration. We use 3.0 by 28 millimeter drug-eluting stent. And then we performed IVUS, which showed stent under expansion. That's why we used 3.245 millimeter NC balloon to perform POCT for the mid-LAD lesion. And then, according to our algorithm, we decided to proceed with DK crush technique for the distal left main lesion because it was Medina 111 and Medina 111, and the angulation was less than 70. And we know from multiple trials that DK crush was associated with superior outcome compared to provision and collet. These are the 17 steps that we are going to discuss. So the first thing is to prepare the lesion. So we started with 2.5 by 15 balloon to dilate the proximal circ. There could be challenged for this balloon dilatation. So if there is a challenge, we usually start with a smaller balloon like Sapphire Pro 1 millimeter or threader balloon. We can also use microcatheter to modify the ostium, or supportive wire like wiggle wire or Iron Man, or also we can use increasing guide support using a guide extension or a side branch anchor technique. If all this failed, we can use atherectomy. So the first step is after preparation is to insert the main vessel balloon, which should be sized according to the distal main vessel, which in this case will be the proxy LAD. So it's very important to deliver the balloon first because it will be challenging to advance a balloon before, after deployment of the side branch stent. So delivering the main vessel balloon first, and then after delivering the side branch stent, we deploy it, and it must protrude at least 2 to 3 millimeter in the main vessel to make sure that we are not missing the ostium. And then after deployment of the side branch stent, we remove the side branch balloon and assess the results. We use IVUS for this. Very important also to assess the results, because if there is any complication like distal edge dissection, it should be treated before crushing the side branch stent or stent under expansion. So in this case, actually, IVUS showed the stent under expansion, as you can see here, with some degree of malopposition. So we decided to use a 3.25 millimeter by 15 NC balloon. We inflated with up to 28 atmosphere to maximize the stent expansion. And then we crushed the side branch stent by inflating the main vessel balloon. And then we rewired the proximal part of the side branch stent with a cyan blue wire. It's very important to try to rewire the proximal part, because as we can see in this case, if we try distal cell crossing, this can result in side branch stent malformation. So this is not recommended. We should use always the proximal struts if possible. And this is an algorithm for approaching difficult to wire side branch. It becomes essentially depends on wire-based option versus microcatheter-based approach. So wire-based option, you can use secondary bend or different wire, more hydrophilic, more torqueable, or wire with a hairpin technique. For the microcatheter, you can advance angulated wire from a straight tip microcatheter, or use angulated microcatheter like Venture or Supercross, or use of dual lumen microcatheter to deliver the wire. Step number 8 is to deliver 2.5 millimeter balloon by 15 balloon to the side branch. Uh, order to perform the first kissing balloon inflation. How can we determine the size? This will be according to Finet's law. So essentially it means the simultaneously inflated balloon have an effective diameter proximal to the bifurcation that is equal to 2/3 of the sum of each balloon diameter. So in our case, we used 2.5 millimeter balloon in the circ and 3 millimeter in the LAD. So 2/3 of this summation is 3.7, and this was close to the left main diameter, which was 4 in our case. After that, we usually use two-step kiss. So we use high pressure inflation in each branch. So we used like pressure at 18 millimeter in the 18 atmosphere at the proximal circ and 16 atmosphere in the proximal LAD, and then kissing at 14 atmosphere in both branch. Step number 10 is to remove the side branch and main vessel balloon and to deliver and deploy the main vessel stent. We use 3.5 by 20. So 3.5 because it should be equal to the distal main vessel, which in this case is the proximal LAD, and 20 to make sure we are covering the proximal left main and to allow at least 8 millimeter for part. And then step number 11 is to assess the main vessel stent result to make sure there is no distal edge dissection. And then step 12 is to perform the first part with 4 millimeter by 15 millimeter NC in the left main. As you can see, we disengaged the guide and we were able to perform the first part. This will be important to allow rewiring of the side branch stent. So rewire side branch stent through the main vessel balloon. This sometimes can be challenging. So initially we use a spider view, and then we were successful in the RA collar view. And then we performed the second kissing balloon inflation. And interestingly, the patient developed transient hypotension, but his hemodynamic improved immediately after dilation. And then step 16 is to perform the second part. And this is important to maintain the circular geometry through the bifurcation. And then we ended with a final IVUS, which showed beautiful results, actually with well expansion of the stent and covering of the ostium of the left main. As we can see, we are here seeing the aorta, so with well coverage of the ostium and well expansion of the stent, as confirmed by IVUS. So in conclusion, non-Nigerian patients with CKD are at very high risk of contrast and nephropathy and need for hemodialysis after PCI. Ultra-low contrast IVUS guided decoy can be performed even in complex left main bifurcation lesion. And as a follow-up, we actually ordered BMB after 5 days, and it showed actually that his creatinine was 1.5, which is much better compared to his initial creatinine that was 1.7. For further troubleshooting, we can refer to this recently published article at Euro Intervention. Thank you for your listening.